Thank you for joining me today. I would like to present to you my PhD title, Dentofacial Anomalies and Intervention Strategies. My name is Borbély Eszter. I'm a dentist and a first-year PhD student. I have two lovely supervisors, Varga Gábor and Ács Lili, and my SMS is Laczko Dávid. My mission is setting the standard in dental anomaly management, and I have a vision of implementing evidence-based practices to address and correct dentofacial irregularities. I have two specific goals as of going on right now. The first one started in September that looks at the maxillary impaction and two surgical exposure techniques, the open and the closed, and the second, which started now in November, where we look at tooth-borne versus bone-borne maxillary protractions in patients who have something called maxillary hypoplasia. The title of my first project is investigating the safety and efficacy of open versus closed surgical exposure of impacted maxillary canines, a systemic review and meta-analysis. A little bit about the background. What is impaction? Impaction is when a tooth fails to erupt into the dental arch within a developmental time frame. The maxillary canine is the second most common tooth that is frequented to impaction after the third molar. The prevalence is about 1 to 3.5% of the population, which translates to 78 to 273 million people. There are some complications with this. First, the functional issues. We can have problems with the occlusion and the bite. Now, imagine you're building a house. What is the most important thing when you're building this house? The pillars. This keeps this house structurally strong and stable. Similarly, in the oral cavity, the canine acts as this structure. It is the longest rooted tooth and helps with the bite and the occlusion. Second is the aesthetic concerns. If you can see in the picture, it's not your typical Hollywood smile, and yes, it affects the appearance of the overall smile and the facial harmony of the patient. The third complication, which might be actually the most important, is the psychological impact. These dental issues can affect the self-esteem of the child and the patient, and maybe they will not have any confidence to smile or do any of these, and they might be very upset and sad. While the closed surgical technique is the most common, it does have actually its problems and complications. What does this mean? It has a potentially difficulty to direct the force, and the unerupted tooth can impact against the adjacent teeth, increasing the treatment times and also the potential for root resorption. The alignment time is also more unpredictable because of the closed flap. In the open technique, however, it is known to be a bit more faster and more stable results. The aim of this is to actually evaluate and compare the clinical outcomes and durations of the treatment phases and the patient-reported experiences between these two techniques. The clinical question that I have brought to you today is, does open surgical exposure reduce treatment time and improve periodontal health compared to the closed technique for impacted canines? The population that we will be looking at is adolescents with an impacted canine undergoing surgical exposure. The incorporator is the open technique, the comparator is the closed technique, and our primary outcomes that we will be looking at is the treatment duration and the surgery time. The secondary outcomes that we will be looking at is things like eruption and extrusion time, the canine alignment time, the periodontal status, failure, the pain, postoperative recovery, and speech and eating difficulties that may arise. The hypothesis is that open exposure of impacted maxillary canines shortens the treatment time and also improves the periodontal health compared to the closed exposure. The clinical implication is establishing a treatment protocol to identify the most safe and effective technique. As you can see, my two domains are listed on the screen. The first domain covering the population and the second domain covering the intervention and the comparator. The amount of hits were found on the three, on Embase, PubMed, and Cochrane, and the key articles are found below. This is the progress of my first project. The topic was feasible. It was submitted to Prospero in November. Before the duplication removal, we had just under 10,000 articles, which resulted after the duplication removal of about 6,500 articles. The title abstraction was completed. We had a Cohen kappa of 0.844, and we are now currently undergoing the full text selection with my pair, Lili Rozgoni. Thank you. Now going to my second topic. The title of my second topic is Evaluating the Efficacy of Tooth-borne versus Bone-borne Maxillary Protraction in Maxillary Hypoplasia. This will also be a systemic review and a meta-analysis. So what is maxillary hypoplasia? Maxillary hypoplasia is an underdevelopment of the maxilla. This is generally known as skeletal class 3 malocclusion. The clinical presentation of this is a midface deficiency, as seen in the picture on the far right, a concave facial profile, and this can actually have things like malocclusion, speech difficulty, and compromised aesthetics. In the picture to the left, we can see the malocclusion. So here we look at the tooth-borne and the bone-borne practices. The tooth-borne maxillary protraction is when we apply external orthopedic forces to protract the maxilla. This generally uses something like a palatal maxillary expansion, and it widens the maxilla to enhance the forward mobility and correcting the transverse deficiencies. There are limitations with this technique. It does require patient compliance. As you can see the child in the picture, she's not so happy. And if the patient does not wear this mask, this treatment is going to fail. The second limitation is also a risk of undesired dental compensations. Because the rapid palatal expander is connected to the tooth, we can have unwanted tooth tipping and things of this nature. The bone-borne maxillary protraction, however, it uses skeletal anchorage devices to apply orthopedic forces directly to the maxilla using mini implants and mini plates. The advantages here is that we do not have these dental compensations that we do have with the tooth-borne, and it does not actually rely on external appliances. So we can have a lot better patient compliance with this. The aim here will be to compare the clinical effectiveness of the bone-borne versus the tooth-borne maxillary protraction in the treatment of maxillary hypoplasia in growing patients with skeletal class 3. The clinical question is, can bone-borne therapies replace the conventional tooth-borne methods for maxillary protraction? The population is adolescents requiring orthopedic maxillary protraction, incorporator bone-borne, comparator tooth-borne, and we have the outcomes below. These outcomes look at the occlusion, the general movement of how the maxilla and mandible have moved along one another. The hypothesis is that bone-borne therapies provide greater skeletal advancements, fewer dental compensations, and more stable long-term outcomes than tooth-borne methods. The clinical implication is to select the most effective treatment modality. Here you can see my key articles. All articles have the intervention of bone-borne and the comparator of tooth-borne. Here's my summary. We plan to submit the first in September of next year and January 26 for the second project. And with that, I would like to close you with a final quote from Phyllis Delaire: "A smile is a curve that sets everything straight." Thank you for your kind attention.
Congratulations for the nice presentation. Who has any question?
Good morning. It was a nice presentation. Thank you for your presentation. It was brilliant, as always. And I'm making notes. One of my first question is that what are the main differences in surgical outcomes between the open and the closed technique that you've mentioned in your presentation?
Okay, so generally for the closed technique, it is a longer surgery than the open one. So in the open technique, the dentist leaves the canine exposed, while in the closed, they actually cover it with a flap. So this is generally more timely, and we can have differences, for example, with the pain. When the flap is made, the patient may actually experience less pain, and yeah.
Between the surgery for each method that you've mentioned, the open and the closed?
So I don't want to make the open technique the bad guy here, but after the surgery, the open technique is generally more painful because it is an exposed site. So the patient does feel more pain post-operatively with the open technique. However, along the treatment, this actually switches. So if the flap is, for example, with a very thick gingiva, the tooth might have very difficulty erupting, and patients who undergo the closed technique may have more pain and longer pain after. But for the surgery part, the open generally has more painful post-operative site.
And visual analog scales and the other would be examined in these visual analog scales when they rate the pain, yes?
Yes.
Good. Thank you for your answers.
Thank you for your
And
questions.
it was a nice presentation.
Thank you.
Thank you. Any other question?
My question is regarding to your first project, that what are the side effects of these surgeries, of the open and closed surgery?
So as I've mentioned, the open technique doesn't use a flap. So because it's open, we can have a more higher opportunity for gingival recession. In the flap technique, for example, since the flap is there, the recession is not so common. Another complication or a side effect could be infection. The flap actually covers the tooth, so it creates a more stable environment, while in the open technique, it's more exposed to food debris and things of this nature, which can cause infection and stuff like that.
Thank you.
Thank you.
Our co-chair also had a question.
Thank you very much. I would like to congratulate you on your
Thank
lecture. I don't have a question, more like a suggestion, because you have just said it yourself that the periodontal status of erupted teeth, in the literature, it tends to be better if a closed eruption technique is used. However, the hypothesis stated just the opposite. So I just would like to suggest you to change the hypothesis to express what you are expecting of the literature, so that it would be much better when you submit the article.
Okay.